Hello, everybody. Welcome to part 19 of our internal medicine review questions. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or in the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. Okay, let's start out with question 1. As you can see, we got a physiology question here. So a 62-year-old man presents to the clinic complaining of fatigue and cough for the past 5 weeks. He says that the symptoms get worse when he lays down, and he needs to prop himself up with 3 pillows in order to fall asleep. He denies chest pain and palpitations, no known history of loss of consciousness. He has a history of small cell lung cancer, which was successfully put into remission with radiation and chemotherapy, including cyclophosphamide, doxorubicin, and vincristine. Vitals are within normal limits. Physical exam reveals crackles at the lung bases and mild pedal edema. Which of the following sets of findings are most likely to be found in this patient? So I'm not going to read through all these, but you can go ahead and look here and then pick one. Okay, so we are looking at right atrial pressure and left ventricular end diastolic pressure. Okay, so let's go ahead and look at the answer. So they both increase. So the way that this question works, and these questions are becoming more and more common on step 2 and particularly step 3, is you have to identify the problem here. And then from there, you have to be able to understand and identify the changes that you would see in labs, in this case, cardiac catheterization. So, let's start with what we've got here. So we've got a patient with who's got difficulty breathing while laying down flat. What is that called? Orthopnea. And whenever you hear this tale of a patient that lays down to go to bed at night, they can't catch their breath, they incline their bed or they put some pillows above their back or behind their back so they can lay more upright, that is congestive heart failure until proven otherwise, okay? Now, there's a number of things that can cause congestive heart failure, so let's look at this patient's history. Well, we don't have any apparent history of hypertension. We don't have any apparent history of like a cardiomyopathy from unknown causes and anything genetic or anything in that regard. We don't have any history of heart attacks. So what do we see? Well, we see that the patient does have a history of radiation and chemotherapy, and this patient had small cell lung cancer. So where's that radiation going to go? To the chest. And we know that radiation to the chest can cause a restrictive cardiomyopathy, and it can also cause constrictive pericarditis, but neither of those are going to give you these symptoms, or at least it wouldn't be the most likely explanation. The most likely explanation to what's going on is that this patient received chemotherapy, and one of the drugs that was given was doxorubicin. Doxorubicin is an anthracycline, okay? And these drugs are infamous for causing dilated cardiomyopathy, sometimes years and years and years after the chemotherapy. It may not manifest until that much later. So the answer here is that this is dilated cardiomyopathy. Now, restrictive cardiomyopathy doesn't cause this sort of congestive heart failure, at least not early on. So dilated cardiomyopathy is the most likely explanation. And so then at that point, all we need to do is figure out right atrial versus left ventricular end diastolic pressure. What are the changes going to be? When you have dilated cardiomyopathy, your preload goes up. You can't pump as hard. Dilated cardiomyopathy is a systolic congestive heart failure, a heart failure with reduced ejection fraction. So if there's increased volumes throughout, then you're going to have increased pressures throughout. It's as simple as that. early on, you'll have more volume in the left ventricle, and the left ventricle will dilate to compensate for that. But once you start developing symptoms, it's because the heart can no longer compensate. So the pressure in the left ventricle is going up. It transmits back to the pulmonary circulation, which then has a transudate causing pulmonary edema, which is what's causing the cracklings. That'll be transmitted to the right heart, which then gets transmitted to the peripheral circulation. That's what's causing the mild pedal edema. So they're increased with both. Now, what about B and D? What about the if we just have an increase in the right atrial pressure and either no change or decrease in the left ventricular end diastolic pressure? Remember, that's the pressure when the left ventricle is done relaxing. So either of these could actually be due to pulmonary hypertension or maybe a interstitial lung disease. In both of those instances, there's more resistance in the pulmonary circulation. And so the pressure in the right atrium is going to go up because it's got to pump against that pressure. And the pressure in the left ventricle is going to go down because there's going to be relatively less blood getting to it. So there could be no change or it could go down, but either of these would be consistent with a pulmonary hypertension or an interstitial lung disease. I suppose you may also see this in a severe pulmonary embolism, but typically we're not doing catheterization on those patients. What about F? What if they were both decreased? What might cause that? Volume depletion. Okay, so if you have less volume, you're going to have less pressure. All right. So here is one of those curves that you probably remember from step one, the pressure volume curves. So as you can see, this is dilated cardiomyopathy, and this in the gray here is normal, and then this in the red here is abnormal. So we're moving that way. There's more volume, but the pressure stays more or less the same. Okay, that's good. But once you start decompensating, then you're going to look more like that. Okay, where now the pressure is going to start going up. So there becomes a point where the pressure will start going up. The heart can no longer compensate. And that does happen in dilated cardiomyopathy. And what I want you to get from this is that anthracyclines are associated with dilated cardiomyopathy. Very important you know that. Okay, question 2. A 62-year-old man presents to the ED due to weakness of his right arm and a right-sided facial droop that began 45 minutes ago while watching TV. Past medical history is significant for a previous transient ischemic attack 2 years ago and an MI 5 years ago. Vitals show blood pressure 145/80, heart rate 90, respirations 12, temperature 98.6. Patient's awake, alert, and oriented. There's right-sided weakness and hemi-neglect. Non-contrast CT of the head reveals no evidence of hemorrhage, and the recombinant tissue plasminogen activator is administered. 20 minutes later, this patient begins vomiting and complaining of a severe headache. CT is repeated and reveals a hemorrhage in the left cerebral cortex. Initial CBC and coag studies on arrival were within normal limits. Which of the following is the best agent to reverse the cause of this patient's bleeding? A, platelet transfusion. B, vitamin K. C, adenosine alpha. Or andexanet alpha. D, idursulizumab. E, cryoprecipitate. Or F, protamine sulfate. Okay. So let's look at our answer. It's cryoprecipitate. Okay, so what is going on here? Well, this is quite clearly a patient who had a stroke. He's got arterial disease, he's had an MI, he's had a TIA, and now he's got sudden onset weakness in the region of the left middle cerebral artery. The right-sided facial droop, right-sided weakness, hemi-neglect. This is very classic for a stroke. We'll just call it a stroke. Okay. Now, whenever you have a patient where you suspect a stroke, the first thing you need to do is determine whether this is ischemic or hemorrhagic. Okay. And how do we do that? Non-contrast CT of the head. Okay. That should be your first step As far as imaging goes, when you have a stroke patient, you need to know immediately, because the treatment for an ischemic stroke is revascularization. The treatment for a hemorrhagic stroke, control blood pressure, stop the bleeding, and keep the intracranial pressure low, or normal at least. Keep it from going up. So with ischemic stroke, we would expect to see no blood in the brain. Whereas with hemorrhagic stroke, we would expect to see blood in the brain naturally. So what do we find? Well, we find no evidence of bleeding. Okay, so then at that point, we know it's ischemic, and we can go ahead with TPA in this instance. 20 minutes later, though, he now is having new symptoms, and these symptoms are, again, consistent with increased intracranial pressure. Vomiting, severe headache. We are worried now about some kind of space-occupying lesion. Well, what do you think is going to be occupying space in a guy that just had a stroke and you gave him TPA? What likely happened is that now he's hemorrhaging. It was fine. You did everything right to begin with. You gave him the TPA, which you were supposed to do after confirming on CT that it was not a hemorrhagic stroke, but now he's hemorrhaging, and he's probably hemorrhaging into the same tissue or around the same area that was ischemic to begin with. So what we have is a TPA-induced hemorrhagic stroke, okay? TPA-induced hemorrhagic stroke. What do you think we need to do? We need to reverse the TPA. Which of these is going to reverse the TPA? Only cryoprecipitate will. So platelet transfusion, this patient doesn't have a platelet deficiency. His CBC was normal. Vitamin K, what's that used for? That's used to reverse warfarin. He's not on that. Andexanet alpha. Okay, so look at the XA there. Remember like rivaroxaban, apixaban, those are factor Xa inhibitors? Well, Andexanet alpha has the XA in it, but it reverses the factor Xa inhibitors. Okay, so it's different. He wasn't on a factor Xa drug. Idarucizumab. So this reverses dabigatran, which is a factor 2A inhibitor. So no. And protamine sulfate, you should know that reverses heparin. So this cryoprecipitate. So here are your drugs we just kind of talked about here, as well as the agents that reverse them. Now, what I want you to pay attention to, and some of you may be asking, well, why do we use cryoprecipitate for TPA, but we use PCC, prothrombin complex concentrate, for other anticoagulant drugs? Here's the reason why. Tissue plasminogen activator, it causes the conversion of plasminogen to plasmin. And that increases fibrin degradation. So it's going to reduce the amount of fibrinogen that you have. Decrease fibrinogen. And so one of the things that we would like to replace is, of course, fibrinogen. Well, fibrinogen is found in cryoprecipitate. Cryoprecipitate has fibrinogen, von Willebrand factor, factor 8, and factor 13. So cryoprecipitate is good to reverse TPA. Now, warfarin, on the other hand, warfarin decreases production of vitamin K-dependent clotting factors. Well, what are vitamin K-dependent clotting factors? 2, 7, 9, and 10. Well, what's in prothrombin complex concentrate? 2, 5, 7, and 10. So you're replacing 2, you're replacing 7, you're replacing 10. That works great, right? You can also use vitamin K. Okay, both of those are the right answer. Now, factor 10A inhibitors, of course, they inhibit factor 10A. Well, there's factor 10 in prothrombin complex concentrate. And then dabigatran, you can also use PCC to reverse that, because remember, that's factor 2. Okay, you can also use idarucizumab, but I imagine that andexanet and idarucizumab are not going to come up on your test, but they could. So you should put that in your back pocket. Okay, now with TPA for reversal, we said we use cryoprecipitate because cryoprecipitate has fibrinogen in it, but you can also use antifibrinolytics. So if you look here, these antifibrinolytics are an aminocaproic acid and tranexamic acid. Tranexamic acid probably comes up a little bit more, but they basically antagonize TPA. They do the opposite. Okay, and you can see here, this is the mechanism by which it works. When you have TPA, it increases plasmin. That's going to speed up the conversion of fibrinogen to fibrinogen degradation products. Okay, so this is why we use the cryoprecipitate. Question 3. A 32-year-old male was found unresponsive in his home by his roommate. He's rushed to the ED via EMS but is deceased upon arrival. The patient has no history of chronic medical or psychiatric conditions. His roommate says that the patient has been down lately but said that he didn't show any signs of wanting to hurt himself. There are no signs of trauma on the body. The parents, who are next of kin, are at the hospital and notified of the death. After expressing condolences and allowing proper time for grieving, which of the following is the most appropriate statement to be made to the parents? A, you may elect an autopsy, which may determine your son's cause of death. B, I strongly recommend an autopsy given your son's lack of previous medical conditions. C, because your son's death was unexpected, it is likely the medical examiner will require an autopsy. D, the police will determine whether an autopsy is needed. Or E, your son's cause of death appears to be suicide and an autopsy is not required. Okay, so what is the answer here? This is an ethics question. This is a professionalism question. You need to know how to behave as a doctor, and maybe some of you are practicing physicians overseas, maybe in Asia, where the ethics and rules are a little bit different. What is the answer here? It is C. Okay, so what is going on? So we have a young man who died unexpectedly. Okay, he doesn't have any known medical conditions, no known psychiatric conditions. He doesn't have the signs that we would expect in a suicide. You know, he's not hanging. There's no gunshot wound with a gun by his hand or next to his body. There is no open bottle of pills. He wasn't on any medications as far as we know. So that's very suspicious, right? We don't know if it's suicide, if it's natural death, or, God forbid, it's homicide. We don't know. And so for that reason, the medical examiner is going to need to know what the mechanism of death is, if you will. Okay, so it's one thing when we know a patient died of natural causes, but we don't necessarily know exactly what it is. That does not require an autopsy. What is going to require an autopsy is when we don't know who caused the patient's death. Okay, was it a suicide? Was it a homicide? Was it natural causes? That's when we need to do an autopsy, because if this is suicide, it needs to be reported, not with the patient's name, but it needs to be reported to public health authorities. If it's homicide, obviously we need to get law enforcement involved. So we need to know. And when you're talking about a mandatory autopsy that the medical examiner orders, it has to be done. Okay, there's no consent involved. So for that reason, you can't elect the autopsy. It has to be done. I strongly recommend an autopsy. Well, yeah, we would recommend it, but it's really not up to us. So that's out. The police will determine whether an autopsy is needed? No, the police do not determine whether an autopsy is needed. They do not order that. The medical examiner does. The police, their only responsibility is to take down information and to keep you safe. That's their only, shall I say, responsibility in the hospital. Okay, they keep you safe by standing outside patients' rooms or inside the patient's room, and they take down information. And, there's laws about that, which I'm not going to get into here, but they're often, sometimes unwelcomingly, a presence in the ED or in the wards. Your son's cause of death appears to be suicide. We don't know that. We don't know that. There's actually nothing here that indicates he may have committed suicide. Okay, he has no psychiatric conditions, no medical conditions, no drugs. There's no sign of trauma on his body. Who knows? Who knows? And that's why we're getting an autopsy. That's why the medical examiner is going to want it. So the answer is C. When is an autopsy legally mandated? When there is a suspicion of suicide. Okay. Now, often the medical examiner will not order or will not require an autopsy when it is abundantly clear that it's suicide. So if there's a gunshot wound to the head, or they were found hanging or something along those lines, they jumped off a building, you're not going to be doing an autopsy in those cases. So it's really suspicion of suicide, not definite suicide. Suspicion of crime for obvious reasons. Unexplained death in an otherwise healthy person. That was our patient. Infectious disease or other public health concern. Let's say somebody's coming back from Uganda and they're pooping out blood, and the patient's wife says this and brings him in and he dies. Well, do you think we're going to do an autopsy? Yeah, we need to know if he had Ebola or something. Death of an inmate in a correctional facility. That's more for legal purposes, and suspicion of medical malpractice. Okay, so remember, if the best way to explain this is if you don't know the mechanism of death, I mean suicide, homicide, natural causes, then you need to do an autopsy. Okay, that's generally how it goes. Question 4. A 32-year-old woman presents complaining of fatigue for the past 2 months. She has a past medical history significant for rheumatoid arthritis. Medications include naproxen and an iron-containing multivitamin. Vitals are within normal limits. Labs are as shown. Which of the following is the best next step in the management of this patient? Let's look at our labs. Okay, you can pause it here now that you've seen the vignette. And let's go ahead and look at our answers. A, infliximab, B, folinic acid, C, splenectomy, D, darbepoetin, or E, iron studies followed by darbepoetin. Okay, so the answer is infliximab. Let's take a look at our labs here, okay? So what's going on? Well, first of all, she's complaining of fatigue. So the first thing we need to look at is the CBC, right? Anytime somebody complains of fatigue, 2 of the things you need to be doing immediately are a CBC and a thyroid panel, okay? So hemoglobin is 8.4. So we know she's got anemia. Okay, question now is what kind? Next thing you want to do, look at the MCV. MCV is low, probably iron deficiency. MCV is normal in the setting of RA, probably anemia of chronic disease, need to get the RA under control. If the MCV is high, probably a nutritional deficiency, B12 folate. There's no reason to suspect that in this patient. MCV is normal. Okay, so it's probably anemia of chronic disease. Okay? So we're gonna say anemia of chronic disease here. Now, another way you can tell anemia of chronic disease is by looking at these iron studies. Serum iron is normal, so that helps you eliminate iron deficiency anemia. TIBC is low. That really signals anemia of chronic disease, because what should happen when your iron levels go down? The TIBC should go up. And when the iron levels go up, the TIBC should go down. If you have a normal iron level but a low TIBC, that suggests anemia of chronic disease. Ferritin, that's our storage iron, that's high. That also points to anemia of chronic disease. In anemia of chronic disease, what happens is that transferrin, or that TIBC, it goes down as a mechanism to deprive bacterial and cancer cells of iron. Now, that is done via inflammation, because bacterial infections and cancer are inflammatory. However, this can then happen in other inflammatory conditions, including autoimmune conditions. Okay, so the likely cause of anemia of chronic disease is hepcidin, which is an acute phase reactant. It promotes iron sequestration. Okay, the iron will be sequestered in enterocytes and in macrophages. So you've got all this iron being stored, but your serum iron is normal and your TIBC is low. That's the classic picture of anemia of chronic disease. The EPO is elevated. It's elevated because the hemoglobin is low. Okay, that's what we would expect. And the SED rate is high, indicating there is inflammation. So inflammation plus anemia plus our iron study picture all points to anemia of chronic disease. So now what do we need to do when there's anemia of chronic disease? Control the underlying condition. Control condition. And how do we do that in the setting of rheumatoid arthritis? Well, RA, usually when we start treating it, we use methotrexate and a steroid to begin with. That's not an answer here. So now, what are the other possible things that can treat RA? Does folinic acid treat RA? No. Does a splenectomy treat RA? No. Does darbepoetin treat RA? No. Does iron studies followed by darbepoetin treat RA? No. Infliximab. It's an anti-TNF drug. It's great at treating RA, particularly RA that doesn't respond or no longer responds to methotrexate. Okay. So here are your comparisons of iron studies in microcytic anemia, particular MCV less than 80, but anemia of chronic disease is kind of set apart in that you can have a normal MCV. Okay, so just bear that in mind. The big way to tell these two apart, iron deficiency anemia and anemia of chronic disease, is the ferritin level. Okay, the ferritin level will be high in anemia of chronic disease. You're sequestering iron. All right, whereas iron deficiency anemia, you don't have the iron, so you don't have any to sequester either. Okay, another way that you can tell this is with anemia of chronic disease, you have anemia, but you also have a low TIBC. You're not transporting iron because you're sequestering it. Okay, you're sequestering it. Now, a couple other things that I would point out here. Another way to distinguish iron deficiency from anemia of chronic disease is in iron deficiency, you're going to have, do I have room for this? Okay, I'm just going to put iron deficiency anemia here. You're going to have an increased red blood cell distribution width. And this is really one of the only things that cause that. And the reason it happens is because you'll have some blood cells that are packed with hemoglobin and others that are really not, and they're smaller. And so rather than having a bunch of uniform red blood cells, you've got this wide distribution width. Whereas with normal, like in anemia of chronic disease, where you're just not making a lot of red blood cells, you've got a relatively small RDW. Okay, so that's another way that you can tell them apart. Now, with the thalassemias, there's varying severities. I'm not going to go into that. Sideroblastic anemia, that's another one you should know. That's generally secondary to something like isoniazid exposure and vitamin deficiencies. Okay, question 5. A 62-year-old woman presents to the clinic with intermittent epigastric pain over the past 6 weeks. She says that the episodes tend to come on at night or when fasting, predictably improving with toast and jam or a cup of milk. She has no significant past medical history and is on a multivitamin. There's been no weight loss or associated symptoms. Vitals are within normal limits. Physical exam is unremarkable. She undergoes EGD and a small non-bleeding duodenal ulcer is found. Biopsy of the tissue stains positive for H. pylori. She started on a regimen of amoxicillin, clarithromycin, and omeprazole. 4 weeks later, her symptoms have completely resolved. Which of the following is the best next step in the management of this patient? A, urea breath test 1 week from now. B, H. pylori fecal antigen test 4 weeks from now. C, H. pylori serum IgG testing 4 weeks from now. D, repeat endoscopic biopsy 8 weeks from now. Or E, no further testing is necessary. Okay, so let's go ahead and find our answer. So H. pylori fecal antigen testing 4 weeks from now. So, okay, all right, so I don't have another slide for this. So let's just talk about this. So this patient, you look at this whole vignette, and you're probably thinking, oh, what do I got to do? I got to do endoscopy, and then it tells you we did that. So always, when you're approaching a test question, first look at the last sentence so that you know kind of what you're going to, how you should be thinking as you're reading. It'll save you time. All right, so what we know is that she's got an ulcer and it's an H. pylori ulcer. What do we then do? Triple therapy. There's also quadruple therapy. Pick your poison. Triple therapy is more commonly on the test in my experience. So she started triple therapy. That's amoxicillin, clarithromycin, and a PPI, omeprazole. And you go on that drug for 4 weeks, and then you check in again, you follow up. Symptoms should be gone. However, we have to confirm eradication of H. pylori 4 weeks after the drug is discontinued. 4 weeks after we're done with the antibiotics. So that's not now, that is 4 weeks from now. So, what we know then is we can get rid of this because we have to check in 4 weeks. We can get rid of this and we can get rid of this because we know we need to do a test for eradication. Well, now it's whether we do a fecal antigen test or a serum IgG test. Why do we not do the serum IgG test? Because IgG is a long-term antibody. That is not going to go away anytime soon, and it doesn't tell you if there's still an infection. Once you develop antibodies, and they're supposed to stick around. Antigen, on the other hand, that's a sign that you have an actual infection. Very similar to, when we have Hep B surface IgG versus Hep B surface antigen. Those are two totally different things. One reflects immunity, the other reflects an active infection. Same thing here. The IgG would reflect an immunity of sorts where the patient has had H. pylori infection in the past, whereas the fecal antigen indicates that we actually still have H. pylori. Why don't we do it right away? Because you may still have antibiotic in your system, which could be suppressing the bacteria to levels that are so low we can't detect it. And then when you discontinue it, and then after a period of time, it could come back. And so that's why we wait to test until several weeks after the antibiotics are discontinued. And then as far as D, repeating the endoscopic biopsy, that really plays no role. I mean, you could go down and you could look again at the ulcer, but this was a shallow ulcer. There was nothing really dirty looking about it. It wasn't bleeding or anything, so there's no reason to do that. Okay, question 6. A 20-year-old woman presents to the clinic complaining of left anterior knee pain for the past month. She says it began gradually, but is now beginning to interfere with her ability to play sports. It has worsened when standing up from a seated position and going up and down the stairs. She's a sprinter for the college track and field team and is currently undergoing a conditioning program after taking the summer off from heavy exercise. She denies trauma. She has a history of menorrhagia, which is controlled with a levonorgestrel IUD. No other medications, vitals are within normal limits. Physical exam reveals a grossly normal left knee, with minimal tenderness to palpation. There's crepitation and tenderness of the anterior knee when compressed during knee extension. Which of the following is the most likely diagnosis in this patient? A. Iliotibial band syndrome. B. Pessin-Serenus pain syndrome. C. Osgood-Schlatter syndrome. D. Patellofemoral pain syndrome. Or E. Patellar tendonitis. Okay, what is our answer? Patellofemoral pain syndrome. Now, this is really challenging because you hear all these things, all these orthopedic things, and, it can be really confusing. Well, one of the things that helps me remember is something like this, okay? So if you know the general region, it can really help you narrow things down. So what did we have here? We had a patient with pain in the anterior knee, not the medial knee, not the lateral knee, not inferior to the patella, the anterior knee, which would often be described to you as on the kneecap. So pain on the kneecap can be a number of things. Patellofemoral pain is the most likely to come up on your exam in a young, healthy patient who's athletic. Prepatellar bursitis, what is this? Okay, this is the maid's knee. So if you're down on your knees all the time, washing the floor and stuff, that you can get some inflammation. There typically be some redness and some very, very, very exquisite tenderness to palpation. On the other hand, this patient's pain was only replicated during compression of the knee. That is the knee compression test, and that is done for patellofemoral pain syndrome. Now, how about these other ones? Iliotibial band syndrome. Okay, I don't have it on this table, sorry. So iliotibial band syndrome is going to be on the outer knee, the lateral knee. Okay, that's the big one here. Lateral meniscus tear, you don't hear about too much, so that's the one I would remember for the lateral knee. The inner knee or the medial knee, that's your MCL tears and medial meniscus tears. Those you need to remember. Okay, those are really important. Remember, we diagnose that with MRI. You've got physical exam things that you can do. You know, you can do your varus and valgus tests. You can do your Thessaly and McMurray tests if you want to memorize those. But that's medial knee. Now, pain above the kneecap, that's the quadriceps tendon, which then inserts into the patella. And below the kneecap, that's the patellar tendon ligament complex. So that's going to be your patellar tendinopathy, which is also known as jumper's knee. Okay, these are patients who engage in jumping sports. So we know that this was a young woman, so it's probably not osteoarthritis or anything like that. She doesn't have any systemic signs, so it's probably not, septic arthritis or an inflammatory arthritis of any sort. What we're looking at here is a more complex pain syndrome that occurs due to sudden exertion. Now, another thing that you may have been thinking of, let's say we take out anterior knee and say leg pain, and it hurts when it's touched or compressed. Then what would you be thinking of, especially with this history of being a sprinter and taking time off and undergoing a conditioning program, sudden increase exercise? What if it was leg pain? What if it was anterior leg pain? You better start thinking of stress fractures, especially in a young woman. Okay, so here's a comparison of three things that can cause more of the anterior or inferior knee pain. So patellofemoral pain syndrome we talked about, that's going to be young female athletes. The patellofemoral compression test is great for that, and I expect you would get told that on your exam. Another thing you could be told is that it's worsened with squatting. Patellar tendinitis, that's just inflammation of the actual tendon. Remember, the patellar tendon is inferior to the patella. It's at the inferior pole of the patella. This occurs in jumpers. Okay, you're putting you're stretching out that patellar tendon when you jump. And so eventually you can get an inflammation there. That's going to be more of a point tenderness at the inferior patella rather than a generalized tenderness at the kneecap. And then Osgood-Schlatter syndrome. This does not necessarily occur in athletes, although it often does. This occurs in young teens. And here I'm talking 12 to 15 years old, maybe even younger. This woman was 20. Now, the reason 12 to 15 is a good age range for this is that this often follows a growth spurt. So look for young teenagers who are athletes who have just gone through a growth spurt. So they're in that 12 to 15 year age range. Okay, so this is more a disorder of puberty or a disorder of early adolescence. And basically what happens here is that the tibial tubercle gets kind of pulled off the tibia. And you can look at x-rays of that, it's very obvious. And this will be pain at a very specific part of the tibia, and it's just in that one little area. Okay. Let's see. I don't think this shows Osgood-Schlatter. So Osgood-Schlatter, though, would be down here. Okay, question 7. A 70-year-old woman presents to the clinic as a walk-in complaining of unrelenting back pain for the past 36 hours. She reports having slipped and fallen on the ice while getting out of her daughter's car. Her buttocks hit the ground and her fall was broken by grabbing onto the seat. She rates the pain as 5/10 and points to the lower vertebra on the midline. She describes it as sharp and says it doesn't radiate. She has no significant past medical history and takes no medications. Vitals are within normal limits. Physical exam reveals point tenderness over the lumbar spine. Strength of back flexion and extension are limited by pain. Lower extremity strength, sensation, and deep tendon reflexes are intact. X-ray of the lumbar spine is as shown. Okay, here it is. The patient is prescribed naproxen for pain control. Which of the following additional measures is recommended this time? I'm going to read through these and I'll show you it again. A, surgical referral. B, epidural administration of methylprednisolone. C, baclofen. D, bracing and limited activities for 4 weeks. Or E, return to normal physical activity as soon as possible. Okay, let's look one more time here. Find the abnormality. And I'm going to be painting on this, so I'm going to switch to red. Okay, so the answer is E, return to normal physical activity as soon as possible. What is going on here? This is a compression fracture. Very common in little old ladies with osteoporosis who slip. So when you're looking at these vertebrae, the top and the bottom aspect should be parallel, okay? More or less. Okay, so notice how these are all parallel, regardless of how they're oriented. Well, look at this. Not parallel. Compression fracture. Okay, very simple. Not a big deal. It hurts, but it's not a big deal. So what we tell these patients, take care of your pain, use naproxen. Maybe we can give them something a little stronger like a Indocin or something like that. But the most important part of this patient's management is a return to normal physical activity. Why? She is 70. If she's bedridden for 4 weeks because she's in pain and she doesn't get up and move, her muscles are going to atrophy and it's going to be harder for her to get around. So we want her to get around. There is absolutely no worry about this fracture. Okay, this fracture is going to heal. However, if she remains bedbound or she's not getting up and moving, that creates a bigger problem. Okay, so we want her to return to normal physical activity as soon as possible. These are the recommendations that you make for a patient with a vertebral compression fracture. Surgical referral, no, this will heal on its own. Epidural administration of methylprednisolone, no, that wouldn't even provide long-term care or long-term management for this patient. Baclofen, no, this is bone pain. This is not muscular pain. Okay, not muscular pain. Bracing and limited activities, no. We want normal physical activity as soon as possible. Does that mean she's got to go out right now and go for a 5-mile walk? No, but it means make it a priority. Do it as soon as you feel able. So our management of vertebral compression fractures, analgesics, avoid muscle relaxants, resume normal activity, very important. So pain control, normal activity, avoid excessive bed rest. A PT referral is great, helps them with strengthening. That's great to do that. I don't think that's going to be the right answer on your test, but if you get this patient on a CCS question, possibly. Vertebroplasty in select patients, if there's refractory pain, we're not there yet. Exercise and fall prevention, evaluation, and treatment of any underlying osteoporosis. Often these patients have osteoporosis, but they may not be diagnosed, so referring them over for a DEXA scan, and then if necessary, treat with bisphosphonates. But I want you to get out of this pain control, normal activity for vertebral compression fractures. Question 8. A 37-year-old man presents to the clinic complaining of worsening fatigue for the past 3 months. More recently, he's been experiencing nausea and itchiness. His past medical history is significant for irritable bowel syndrome, which he was told he had when he went to urgent care 3 years ago and described his occasionally bloody stools. He is not on any medications. Vitals are within normal limits. Physical exam reveals a mild yellowish discoloration of the sclera and linear excoriations of the arms. Otherwise unremarkable. CBC reveals a microcytic anemia. Percutaneous liver biopsy is performed and reveals fibrous obliteration of the intrahepatic bile ducts with concentric deposition of connective tissue. Which of the following is the most likely diagnosis in this patient? A, primary biliary cholangitis, B, primary sclerosing cholangitis, C, autoimmune hepatitis, D, hemochromatosis, or E, cytomegalovirus hepatitis. Okay, so go ahead and pause it if you want. Remember, you probably want to take about a minute for each question as you go through, and then that'll give you some time to go back. Keep an eye on that clock. So the answer here is primary sclerosing cholangitis. How do we know this? Okay, so first of all, what we know is that this patient has jaundice. Okay, sometimes jaundice isn't going to, come right out and kick you in the face. Sometimes you just see scleral icterus. However, if you see scleral icterus, that is jaundice. Okay, so yellowish discoloration of the sclera. So we know the patient's jaundiced. Okay, so we know there's something liver going on. Something liver going on. Well, all of our answer choices are liver. So now we're going to have to go back and look what might give us a hint. Well, we got a guy who went to urgent care 3 years ago and described occasionally bloody stools, and he was diagnosed with IBS. Does IBS cause liver problems? No. But does IBS have occasionally bloody stools? No. No, 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 no. IBS is only pain, you poop, the pain goes away. Pain, you poop, the pain goes away. Okay, now that poop is usually going to be either diarrhea or constipation, but the poop is normal. There's never blood. Okay, never, ever, ever is there blood. There's not mucus. It's normal. Okay, IBS is a pain syndrome. On the other hand, inflammatory bowel disease, yes, you can get blood. And yes, it's painful, but the blood is present most of the time. You'll also have signs like weight loss and fever and elevated white count, elevated sed rate, all those inflammatory signs. This guy had inflammatory bowel disease. He didn't have no IBS. He had inflammatory bowel disease. And so just then based on that, gone, gone, gone. Okay? PBC or PSC. These are both autoimmune conditions. Which one is associated with inflammatory bowel disease? B. Primary biliary cholangitis is very much women, and primary sclerosing cholangitis has a male preponderance. But this one is associated with inflammatory bowel disease. Now, the microcytic anemia, that's just an anemia of chronic disease here. Now, you could also have approached this a different way. If you know your pathology, then you know the answer. Right? Percutaneous liver biopsy shows fibrous obliteration of the intrahepatic bile ducts with concentric deposition of connective tissue. Deposition of connective tissue, that's sclerosis. So you can imagine it's got sclerosis in the name. So primary sclerosing cholangitis. Autoimmune hepatitis has to do not with the biliary ducts, but with the hepatocytes themselves. So here's a comparison. What I want you to do is I want you to memorize these antibodies because they come up. Autoimmune hepatitis is a hepatocellular pattern because it's nothing to do with the bile ducts. That's going to be anti-smooth muscle. Primary biliary cholangitis, think of women with other autoimmune disorders. Lupus, Graves' disease, RA, Sjogren's. That's going to be anti-mitochondrial antibody or AMA. And then primary sclerosing cholangitis, this has a slight male preponderance. Inflammatory bowel disease. Remember that association? This is P-ANCA. Okay. Now, if you want to look at the histology, go ahead. I'm not going to spend too much time on this, but what I would remember are these words. Okay. Autoimmune hepatitis, that's only going to affect the hepatocytes. There's not going to be any change to the biliary ducts. Okay, so you'll see inflammatory cell infiltrate into the liver. Very simple. Primary biliary cholangitis is granulomatous, and primary sclerosing cholangitis is sclerosing. So you have this onion skinning deposition of connective tissue. Here's primary sclerosing cholangitis. You can see the onion skinning here. Okay, and this is not very cellular. You can see some cells here, but it's not very cellular. This is a normal bile duct. So you can see that there's lots of deposition around the bile duct. Now this, on the other hand, this is primary biliary cirrhosis, or cholangitis rather. That's the old term. Now what you see here is lots and lots of cells around the bile duct. That's PBC. This is autoimmune hepatitis. You can see they're not surrounding the bile duct. They're just interspersed within the hepatocytes or around the hepatocytes. All right, question 9. A 52-year-old man is brought to the ED by law enforcement after he was found harassing a group of tourists. He is confused and appears disheveled. He has no identification and is not oriented to person, place, or time. When asked for his name, he responds that his name is Jesus Christ. Vitals are within normal limits. Physical exam is remarkable for an emaciated and ill-appearing man. Heart and lung sounds are normal. Abdomen is soft, non-tender, non-distended. Pupils are equally round and reactive to light, but extraocular motions are restricted on leftward gaze. Deep tendon reflexes are normal. Gait is ataxic. The remainder of the exam is unremarkable. Labs are shown. Here's our labs. Okay, let's go back and I'll show you those again. Which of the following is the best next step in the management of this patient? A, IV lorazepam, B, PO lorazepam, C, normal saline bolus, D, PO lactulose, or E, IV thiamine? Let's look at those labs again. Okay. Now, I'll let you see the answers here. Go ahead and lock your answer in. So now we're going to do a follow-up question. After appropriate treatment, 2 days into admission, the patient appears healthier and is oriented to person, place, and time. On his chart, nurses remark that his stated history doesn't make sense. He claims to currently work for the coal mines, which shut down 30 years ago. When asked how he's going to find a way home, he calmly says that he just got off the phone with his sister and she's going to pick him up. However, after reviewing the nursing notes, he told his morning nurse that he's a mechanical engineer and has no children. Or in this case, we'll just say siblings. Okay? Aside from a flat affect, the patient appears well. He's able to button his clothes, operate the remote control, and name the last 3 presidents. Which of the following structures would most likely appear abnormal were neuroimaging performed on this patient? A, frontal lobes, B, basal ganglia, C, hippocampus, D, mammillary bodies, or E, internal capsule? Okay, so let's go ahead and look at the answer to question 9. So remember, question 9 was asking you, what do we do with this guy who's confused and disoriented and was harassing tourists and thinks he's Jesus Christ? We're going to give him IV thiamine. Okay, why? What is going on? He is confused. He is an alcoholic. And he has cerebellar signs. What is this? Wernicke's encephalopathy. Anytime you hear an alcoholic who's sober but is still confused and is walking around like he's drunk but he's not drunk, you got to think Wernicke's encephalopathy. Now, some other things that you see with Wernicke's are restricted extraocular movements, so particularly on lateral or side-to-side gaze, so in this case, leftward gaze. He's got the ataxic gait, but he doesn't have any other signs of upper motor neuron damage. The deep tendon reflexes are normal. Okay? So this is Wernicke's encephalopathy. Why does Wernicke's encephalopathy happen? Low thiamine. Low thiamine. Okay? Now, for that reason, we're going to give him thiamine before we give him fluids. He's going to need fluids. He's an alcoholic. He's disoriented. He can't drink his own water. But if you give fluids before giving thiamine in a patient with Wernicke encephalopathy, their symptoms are going to get worse. And so for that reason, we have something called a banana bag. I should have put a picture of that in there, but if you've worked in the ER, you'll know exactly what I'm talking about. We give that when we need to give fluids to a patient who's clearly drunk or an alcoholic or has a known history of alcoholism. So it's often a good idea because thiamine is not going to hurt anyone. You can't get sick off thiamine or anything. It's not like giving vitamin A or something like that where it's lipid soluble. Here we're talking about a water soluble vitamin. It doesn't hurt to give. Okay, lorazepam, that would be if this patient was tremulous and anxious and was withdrawing. So neither of those. Normal saline bolus, we talked about. Lactulose, that would help for hepatic encephalopathy, an elevated ammonia, but he doesn't have that, so it's thiamine. Let's look at his labs, though. So he's got a mild anemia. MCV is high, so he's probably got a B12 or folate deficiency on top of that, and that's really typical. When you got a patient with one vitamin deficiency, they often have others, especially within alcoholism. Sodium was 133, potassium 3.4. Also, electrolyte imbalance, something you commonly see in patients with alcoholism. AST and ALT are elevated. The AST much higher. That suggests alcoholic hepatitis. Albumin is low and INR is elevated. Remember, you make factors in your liver, which then will help you clot. So both of those imply a synthetic deficit of the liver. So this guy has got alcoholic cirrhosis, okay? And then he's also got these electrolyte imbalances. So we know he has severe alcoholism. This has been going on for a long time. Okay, so question 10 is asking you what is going on. Okay, so this guy had Wernicke encephalopathy, but for the most part now he's fixed. So he doesn't have the gait disturbance, he doesn't have the ophthalmoplegia, he doesn't have the altered mental status. But what he does have now is this weird lying, fibbing confabulations. This is confabulation. Now, what is the difference between a lie and a confabulation? Confabulations are honest liars. Now, do we necessarily know that from this? Maybe not, but when you've got a patient who's lying and they have no reason to lie to you, you should really think of confabulation, especially in the setting of an alcoholic. So this is Korsakoff psychosis. And it is very commonly, but not always, seen along with Wernicke encephalopathy. Now, these patients will have retrograde amnesia. Okay. They'll also have anterograde amnesia. So retrograde amnesia is difficulty retrieving past memories. So he might forget what he had, things that happened over the past 2 weeks. But it's not going to be things that happened 10, 20, 30 years ago. Those are going to tend to be your dementia patients that forget their wife or forget their kids' names or forget where they grew up. This is not going to happen in plain old retrograde amnesia with Korsakoff psychosis. They will remember how to get home. They will remember who the last 3 presidents are. They'll know their procedural memory, like how to operate a remote control, how to button your clothes. But what they might not remember is, they bought a new car last week and he might forgot that he bought that car. Or anterograde amnesia. So he has the Korsakoff psychosis. It was diagnosed yesterday. This morning he had bacon and eggs for breakfast. You ask him what he had for breakfast. 2 hours later, he can't remember. That's anterograde amnesia. So they have amnesia and confabulation. In the setting of alcoholism, it's Korsakoff psychosis. Now, at that point, all you need to know is the pathophysiology of Korsakoff psychosis affects the mammillary bodies. You just have to know that, okay? There's no real mechanism for you to memorize there. You just need to know that, mammillary bodies. And you should know how to identify where they are on a CT. If you don't know how to do that, go look it up. Frontal lobes, what is that injured in? That'd be your frontal temporal dementia. Okay, they have personality changes and language deficits. The personality changes, impulse control, that's frontal lobe. Basal ganglia, no, those are movement disorders. That would be like your hemiballismus or Parkinson's or Huntington's. Hippocampus, yes, that plays a role in memory, but not this disorder. Internal capsule, that carries your motor fibers. You would see paralysis here. So it is mammillary bodies. Wernicke-Korsakoff syndrome, we already talked about this. It's called one syndrome, but there's 2 separate entities. Usually if it's Wernicke's encephalopathy, that's more likely to be by itself. That is our encephalopathy, oculomotor dysfunction, and ataxia. But if you have Korsakoff psychosis with the amnesia and the confabulations, you will tend to have a history of Wernicke encephalopathy as well. This is kind of more severe. But you could have one or the other. Now, again, remember, Korsakoff psychosis is not dementia. Their cognition, their attention, their long-term memory are all well preserved. They just have some amnesia and some confabulation. And remember, this is very important. IV thiamine before fluids, okay? If you give fluids right away, the Wernicke encephalopathy is going to get worse. And so the Wernicke encephalopathy will improve with thiamine replenishment. However, Korsakoff psychosis tends to stick around a little bit more, and that's harder to fix.